Welcome, and thank you for making time for this session. My name is Paul Bruning, and I am the Division Administrator for Sports Medicine and Hand Surgery at Duke University, and also the current President-elect for the AAOE. Today, I'd like to talk about the Medicare bundled payments. Where have we been? What have we learned? And most importantly, where are we headed next? Because it affects every orthopedic program out there. We're going to move through three different sections. First, BPCI, the original bundle payment experiment. Secondly, we'll talk about CJR, the mandatory joint replacement model that just wrapped up its most recent performance year. And third, and this is the headline, is really CJRX, the proposed nationwide mandatory model CMS wants to launch October 1st of 2027. And this affects really every hospital that bills Medicare Part A and B, and it will very likely be affecting you. The takeaway for this session is really that BPCI was CMS's first large-scale test of episode-based bundle payments, paying a single price for an entire episode of care instead of paying separately and for each individual service that was provided. Four things kind of stand out from the results, and that set a pattern for everything that came about and CMMI has done since that period of time. The first is that it reduced Medicare spending. BPCI did reduce Medicare spending, and especially concentrated within orthopedics. Major joint replacement episodes saw the strongest savings of any of the conditions tested, averaging roughly 2,200 per episode among successful participants. Savings were generated almost entirely from post-acute care. Fewer unnecessary skilled nursing facility stays, more patients discharged home when it was clinically appropriate, and not from cutting corners or from hospital stay itself. Quality held steady. Readmissions and other major outcomes didn't budge even as post-acute spending came down. But performance across the other aspects, other medical conditions involved in BPCI was uneven. While orthopedics flourished, some of the other programs did not. But this was what drove CMMI to further consider work within bundled payments, especially for orthopedic conditions. The next model was CJR, or the Comprehensive Care for Joint Replacement. Unlike BPCI, CJR was mandatory, but only in selected markets, and it was scoped specifically for hip and knee replacement. Hospitals were on the hook for total cost and quality across the hospitalization, plus a 90-day recovery window. The most recent CMS reporting, covering performance years 21 through 23, gives us the clearest evidence yet. 112.7 million in Medicare savings across more than 98,000 patients in 323 hospitals. Quality maintained on complication rates, mortality, readmissions, and ED utilization. Savings didn't come at the expense of outcomes. Once again, the savings engine was reduced institutional post-acute care and tighter care coordination after discharge. CGR pushed real care transformation, closer physician-hospital alignment, standardized clinical pathways, more patient-reported outcome tracking, and more deliberate discharge and home recovery planning. So twice in two different models run years apart, CMS had gotten similar answer. Bundled joint replacement payment saves money without hurting quality. Consistency is what CMS is looking for and wants to continue to expand on. So if we look at this and evaluate connecting the dots, what is it that we're seeing? Where have the two programs come from? BPCI approved bundled payment works, and it works best in orthopedic joint replacements. CJR proved that mandatory participation sustained over years keeps delivering savings without sacrificing quality, which brings to the next logical step that CMS is trying to propose and continue to work towards, is that take what work we have done selecting markets and make it the law nationwide for every or nearly every hospital. Expand on the success that they've been seeing and continue from there. On the horizon is a comprehensive care for joint replacement expanded model. This will take effect October 1 of 2027. And this is a mandatory model for hospitals, part of the inpatient payment system or the outpatient payment system. So this will include HOPDs, whereas prior models were mostly related to inpatient. So what is CJRX and what is being proposed? CJRX is CMS's proposed mandatory nationwide bundle payment model for hip, knee, and ankle replacements in both inpatient and outpatient settings. For original Medicare patients, holding hospitals accountable for the 90-day episode from the procedure through recovery. So where we have seen some models that had shifted to a 30-day, such as in teams, this returns to the 90-day post-op model. So operationally, this is mandatory nationwide participation. All acute care hospitals paid under IPPS and OPPS across all 50 states, DC, and the US territories are included. The procedure scope is outpatient 27130 and 27447 performed in the HOPD, and it includes inpatient then for DRGs 469, 470, 521, and 522, which does include hip fracture cases. The episode scope is broad, essentially all related Medicare Part A and B services from the initial procedure through 90 days post-discharge, hospitalization, home health, physical therapy, any other remissions are included within that total cost of care. Concurrent participation in MSSP ACOs is allowed, but concurrent participation in a team model is not. So team model participants are excluded from this mandatory bundle. And also one caveat is for Maryland hospitals, they're excluded due to their separate all payer rate arrangements. The practical message is that unless you're a critical access hospital, rural emergency hospital, or you're in Maryland, or that you have a team participation model and you do not want to participate, outside of those, all hospitals should plan on participation within CJRX. One thing that is new is more around the composite or this quality measures and what's called a composite quality score. So cost isn't the only thing. Quality gates the payment. CMS proposed 5 quality measures rolled up into a single composite quality score, or CQS. It's scored on a 0 to 20 point scale, and it's done against national benchmarks. These fall into 3 domains. Clinical outcomes, the hospital level risk standardized complication rate following elective primary total hip or total knee arthroplasty, and hospital visits within 7 days of an outpatient department procedure. Patient experience is now considered. The HCAHPS for inpatient or the OAS caps for outpatient are part of this quality score. Patient reported outcomes, the hospital level THA, TKA, patient reported outcomes based performance measure, or PRO-PM, and CMS have signaled its intent to weigh this one more heavily than it's been weighted under prior models. In prior models, it's basically been, have you been collecting the PROMs? Here, the PROM score is actually going to be weighted into the CQS. All 5 measures are pulled from data that you've already probably been looking at, or have been reporting in one way or another through CMS quality programs. So there's no brand new reporting burden within the CQS, but there is a new financial consequence attached to the performance. So if you haven't been tracking those closely, especially the PROMs, you will probably want to start doing that, because the score here, lower scores will result in discounts to your targeted price, and that could lower your target price, making it even more of a challenge to hit that rate and achieve savings. So in essence, what we look at is if you're 0 to 20 score, if you're scoring over 17, there is no discount. So what your target price is what your target price is. If your quality score is between 12 and 17, you're seen as good, but your target price will be reduced by 1%. If you're between 6 and 12, on the quality score, it's acceptable, but your target price is reduced by 2%. Now, if you're acceptable, good, or excellent, you're eligible for savings. That continues, whether you're from 6 to 20. Okay. If you're at 6 or below, it's considered below acceptable. You're no longer eligible for reconciliation payment. So you have no upside to this, no upside risk. If you do maintain downside risk, where if you're over and you're above the target price, you could have repayments due to CMS, and your target price is going to be reduced by 2%. So this is an interesting proposal, an interesting look at it to continue to try and maintain the quality, but now your proms are actually being utilized to look at the quality comparative to other benchmarks in the area, and it could result in combination with your patient satisfaction scores and your other clinical risk categorization, in discounts and potentially the loss of the eligibility to receive positive payments. So in terms of what are our key takeaways, evidence is consistent that BPCI and CJR both have showed the same thing years apart. Orthopedic bundles save Medicare money without hurting quality. CMS is acting on that consistency. CJRX is a proposed rule. The direction involved in it is becoming more clear all the time. Final rules are expected to be proposed in August and October of August of 26 for institution in October of 27. Most likely, what we're seeing now is going to continue on. I don't suspect many changes to what has been proposed, which includes knee, hip, and ankle. The scope has expanded in every dimension: mandatory instead of selected, markets nationwide instead of regional, ankle's been added to hip and knee, outpatient has been added, so it's no longer just inpatient, fractures are components to it. So this is a continued growth of CMS's drive towards what they have accomplished in bundled payments, and to try and build on that and continue to grow their program. Quality is not a checkbox anymore. Your composite quality score directly determines whether you can earn a reconciliation payment at all, and PROMS performance is being weighted more heavily than before. Post-acute care coordination remains the single biggest lever in every model to date. That's where the savings and the risk have lived. That's where we can make a difference. Organizations that did well under CJR started building discharge planning infrastructure and preferred post-acute partnerships early. The recommendation is don't wait. Start working with your hospitals. This isn't just about hospitals. This is also about the private practices. What can you do with the hospital to build and grow the savings and work together and produce a positive bundled payment experience? We've seen that private practices are able to own bundles and they're able to perform well. CMS has seen the biggest positive results working with hospitals, which is why the ownership is probably there right now, but it doesn't mean that the private practices can't be involved. Now's the time to get involved with your hospital, work on shared savings, co-management agreements, develop the programs together, because we're all in this for helping out the patients.